And I have 1:30. For those that have joined this afternoon, I'm Becky Royer, and I'm subcontracted by the State Office of Rural Health to work on the Medicare Beneficiary Quality Improvement Project work. And it's my pleasure to introduce to you Becky Sanders. We're going to begin the last portion of our day, and I hope everyone has enjoyed the content that has been shared so far, because I know that the information that Becky Sanders is going to be sharing is going to be very helpful to you. Becky is kind of what I think as a go-to person for all things when it comes to telehealth. She's helped individuals on everything from billing to implementation to buying equipment, providing additional education and support, doing some simulations. So she's just a great resource for us. So to kind of give you some background for those of you who don't know Becky, she's the senior director at the Indiana Rural Health Association, and she engages with others on the other senior directors there on the IRHA executive team and strategic planning and guidance and the future for IRHA. But in addition to that, she also serves as the program director for the Upper Midwest Telehealth Resource Center. And the center serves as a single point of contact for telehealth resources through educational presentations, individualized technical assistance, facilitation, and connections to telehealth information via the website and program staff. And they serve the states of Illinois, Indiana, Michigan, and Ohio. So we're very honored to have Becky here available to us right here in Indiana. Becky also has a Lean Health Care Black Belt certification from Purdue Health Advisors, and she is a past National Rural Health Association Fellow. So Becky, I'll let you take it over.
Thanks so much, Becky. I'm so pleased to be asked to speak to all of you today, and a special shout out to Brent. After all of our breathing, I feel much better. All right, so we're going to talk about telehealth today, and just a little bit of, throughout the day, we've talked a lot about COVID. I mean, it has changed our lives so much in this past year. So I will speak a little bit about how it has influenced what's going on in telehealth today and what we've seen across our 4-state region, and then more specifically here in Indiana. So we'll start with just a little bit of history just to set the stage, and then we'll talk about some different regulatory changes based on COVID. And then what probably everyone is most interested in is, how do you continue to see your patients with telehealth or virtual visits or video visits? The terminology is changing on that as telehealth becomes more popular. But what do you really need to do to see your patients at home and provide that same level of clinical care? All right, so here's just a little bit of history on telehealth. I mean, you could argue that it started back 500 BC with smoke signals from community to community. But really things picked up with the invention of the internet and NASA going to the moon and ARPANET and all of those things that predated the internet. In the late 1990s, the American Telemedicine, I'm sorry, I was just looking at that. So in 1993, the American Telemedicine Association was formed. And I believe it was 97 when Medicare became the first payer for telehealth services. And they've kind of set the standard as we've gone forward from that. So that'll be, we'll come back to that. But a lot of what is done with telehealth and telemedicine, I mean, everybody wants to do the right thing for their patients. But if it's not financially viable, we were just talking about it in our last session, at the end of the day, it's got to make financial sense for the organization as well. All right, so the Upper Midwest Telehealth Resource Center, under the umbrella of the Indiana Rural Health Association, has been around since 2011. And I came on as director in 2012. And, at the very beginning, it was It's kind of like we were cheerleaders and visionaries out in the middle of Lake Michigan. I like to use Lake Michigan as an example because our states border Lake Michigan. But it was like we were on this little rowboat in the middle of Lake Michigan, and not too many people paid attention to us. But then last year we saw the global pandemic with the coronavirus and COVID-19. And then a lot of people started listening to us. We were inundated with questions and requests for presentations. So now I feel like we're this big cruise ship in the middle of Lake Michigan, and a lot more people take notice of us. So the pandemic that we've been under has really changed the way healthcare is delivered today. Those in the telehealth, telemedicine industry will tell you that policy moved forward like 20 years overnight last March, and it certainly felt like that. But many healthcare organizations that had never before thought about having a telehealth program and using that as a modality to deliver care, they've embraced virtual care, and it's brought to light some interesting pros and cons. So as a program, the UMTRC is funded by HRSA, and we have to report our data to HRSA, and we had to create this for one of our reports, and I liked it so much that I've been using it in my presentations just to emphasize how much we have seen telehealth growth here at our Upper Midwest Telehealth Resource Center since 2017. So you can see that year-over-year growth and the increases each year. And technical assistance or TA requests, anytime that we get an email through our website or a phone call, or we connect with someone through a virtual event, or soon we'll hopefully have some in-person events coming up. Those we consider technical assistance requests, and we document them in a national database with all of the other telehealth resource centers around the country so that we can see trends across the country and show data that tells HRSA our story. So here's a couple other graphs here. At the top, you get to see this year-long view. This is from January of 2020 to December of 2020. So you see our technical assistance requests around the country were down here in this range, under 20 for the most part. And then they shot up to nearly 80 per month during March and April when the pandemic first hit the United States. And then you can see here, things have fallen off a bit, but still, when you compare month over month, there are many times that we are still having more requests than we did prior to COVID. The same thing here, outreach is presentations like I'm doing today, or trainings or workshops, those types of things. And also you can see the trends in our website visits as well. Here you can see the different types of organizations that reach out to us. And the majority of our technical assistance and our requests do come via email, and the majority of what we send back to people is done via email. Just a couple other graphs looking at the data nationally from all the 14 telehealth resource centers. There's 12 regional telehealth resource centers around the country, and then 2 national centers, one for policy and one for technology. Again, you can see that huge leap in the data points in that March and April timeframe last year. So what happened in March and April last year? Well, a lot. We saw CMS add 80 new CPT codes for reimbursement under Medicare for Medicare beneficiaries, and they added the 3 audio-only codes to the list for telehealth services as well, and we'll come back to that in a moment. The biggest regulatory change, in addition to those CPT codes, was that Medicare took away 2 of the 4 conditions of payment. They eliminated the geographical barriers so patients could be at home, and also so that being at home and not being at a designated clinical originating site was huge. But even more than that, they said patients can be anywhere. They can be in rural areas or urban areas. So this really changed the playing field about what was reimbursable for Medicare beneficiaries. Also, there was a lot of discussion among various partners and consumer agencies for occupational therapists and speech language pathologists and physical therapists about trying to be able to continue care with their patients for those particular disciplines. And those ended up having expanded roles, so they were able to practice and see their Medicare patients for the very first time via telehealth and get reimbursed. And then there were other waivers and executive orders at the state level and at the federal level around supervision and around how many days between a telehealth visit in an inpatient setting or in a skilled nursing facility setting. Then this proposed calendar year 2021 physician fee schedule. The National Policy Center, which is CCHP, that you can see in that icon up in the upper right-hand corner of the screen. They're our National Policy Center or Telehealth Resource Center Policy Center. And every time there is a large event that affects telehealth reimbursement, they put together a fact sheet. So every year, traditionally in July, CMS has released a proposed physician fee schedule for the following year. In 2020, it did come out in July as normal at the end of July. And then by August, the staff at CCHP had been through the entire proposed rule, picked out the stuff that was important to telehealth reimbursement, and to put it together in this fact sheet. So hundreds and hundreds and hundreds of pages were reduced down to, I think, 6 pages in this particular case. So much easier to digest. And this link here can take you to that document if you're interested. So some of the different things in March that affected telehealth reimbursement, I've got them dated here, different bills that went into effect, telehealth fact sheets, waivers, and then the CARES Act was one of the biggest ones. So it seemed like last March, every time we turned around, the answer that we gave the previous day wasn't true anymore because a new piece of legislation had come out. So it was a very challenging time. In response to all of that, and this still continues on our website today, we have specific pages for each of our states with the state executive orders that have come out affecting Medicaid policy and reimbursement. So you can go out there and check out that information as well. So coming back to Medicare, I mentioned that there are conditions of payment, and we're going to look at those on the next slide, but just wanted to stress that prior to COVID, it was important to know if a clinical site, a rural health clinic, a federally qualified health center, or critical access hospital, if they were in a designated rural area per HRSA or CMS rules. And there's a website that I'll show you in just a moment that you would put in your address of your clinical site where the patient was going to be during the telehealth event. And they would either say, yes, it's eligible for reimbursement, or no, it's not. And then Medicaid, each state has their own flavor of Medicaid policy and has the ability to tailor it to the needs of their beneficiaries. As of spring of 2019, all 50 states in the United States and the District of Columbia did offer some type of reimbursement for telemedicine in a live and interactive format. So these are the 4 conditions of payment for Medicare that I was talking about. The patient had to be outside of a metropolitan statistical area. They had to be physically located at a designated originating site. The services provided had to be within a certain CPT code range. and the services had to be delivered by an eligible practitioner. So right now, during the pandemic, these first two are waived. That's all the geographical location information. And then the services have been expanded, and I mentioned the speech language pathology and the occupational therapy and physical therapy. Those have been expanded as well. This is the website prior to COVID where you would go to figure out if the originating site where the patient was going to be was indeed in a rural area for Medicare telehealth reimbursement. And that again is waived during the pandemic. So this document is our gold standard for understanding telehealth reimbursement when the patient is a Medicare beneficiary. This MLN network or Medicare Learning Network booklet is that document. It came out on March 17th last year, right as the pandemic was really taking hold in the United States. And the 2021 version, we're still waiting on that. A lot of that is held up because we have a new administration in the White House. It takes a while for the confirmation of all the secretaries, and it's slower to move things through the official channels. But we should see that in the next month or so. This is an example of what it looks like, the different services and the associated HCPCS or CPT codes. Now, when you go to bill for telehealth reimbursement, it's not that different from billing for an in-person service. Here we have the rural or originating or spoke site. This basically means where the patient is physically located during that telehealth session. And depending on if you are reading a Medicaid document or a Medicare document or a commercial payer document, you might see either the term rural or originating or spoke, but they all mean the same thing. They're talking about the patient site. So if the patient was at a clinical location during the telehealth services, then that location would bill on their Part B form the facility fee using the CPT code Q3014. It's only about $26, but it's a little bit of money to help recover the time for the staff to home that patient or room that patient for that telehealth visit. The other side of the equation is your Part B professional fee for the clinical provider. Again, depending on what type of document you're reading, Medicare, Medicaid, commercial payer, they might refer to this as the urban site or the distant site or the hub site. Basically, they mean the provider site. Where is the provider physically located during that event? That the provider fee is the same CPT code that they would use if the service was provided in person. And there's just different modifiers that are used. The modifiers vary depending on which insurance is being billed: commercial insurance, private insurance, Medicaid, Medicare. With Medicare, they want the place of service 02 to indicate that the service was provided via telehealth. And lastly, if the patient's at home, you are not going to bill that Q3014 because there is no rooming of the patient that originating site needs to recover. Last year, when the Medicare Learning Network fact sheet came out, I know that it came out on the 17th because of this link here. The fact sheets that CMS put out and all of the frequently asked questions are all still available if you want to dig into that policy. For the state of Indiana, we have on our umtrc.org website under resources and reimbursement different documents, two for each state that we cover. One that talks about provider reimbursement and from a hospital perspective, and another that talks about from an RHC or FQHC perspective. We have kept these up to date and do continue to do that as things change. So this is updated as of October 4th of last year. And as you read through this, you see that Indiana has always talked about telehealth technology being a real-time interactive patient-provider engagement. You can reference the different bulletins that IHCP puts out for all of these different information. So the modifier for the state of Indiana Medicaid billing is GT, to indicate that the service was provided via telehealth, and that changed. It was suggested, but now it changed to required as October 24th, 2020. And here the IHCP telemedicine service codes previously was the POS02 and modifier 95. So that changed last October. Some more information, and here's all of the bulletins if you wanted to go back and see the evolution of how we got to where we are now. Very important as I go back through some of the things that came out with the 2021 physician fee schedule. So our new Secretary of Health and Human Services, Xavier Becerra, was confirmed on March 18th of last month. And April 15th of this month, he extended the public health emergency for another 90 days. So now from a federal level in the United States, the public health emergency does not sunset until July of 2021. This is important because of what we're going to see as we talk about the 2021 Medicare reimbursement codes for next year. And this 90-day extension is in keeping with what the Trump administration had done since the beginning of the coronavirus pandemic. So in the 2021 physician fee schedule, I talked about 80 new codes being released last March. Well, they took about 60 of them and made them permanent in the Medicare fee schedule for telehealth reimbursement. So here's a list of those codes. You see a lot of things around behavioral health, custodial services, home visits, cognitive assessment and planning, and some complexity for certain office visits, for E&M services and prolonged services. Now the other codes have been added to what's called a Medicare Category 3 list. And so they will only be reimbursed through the end of the calendar year that the PHE, or the public health emergency, concludes. So that's why it's so important to know when the public health emergency is going to end or sunset. Since the public health emergency was expanded or renewed into January with the Trump administration, and then again before the inauguration of the Biden administration, and again to April of 2021, we were already set that for 2021, we know that these codes are going to be available for reimbursement through the end of the calendar year of 2021. Now, if the Biden administration continues to renew the public health emergency to the point that it gets into January of 22, then these codes will still be available for reimbursement until the end of 2022. Does that make sense? So again, you can see these psychological and neuropsychological testing. So these are, if we look back to one of these categories, so psychological and neuropsychological testing, CPT code 96121 is like the lowest level on that. And then here we've got 96130 to 133, 96136 to 139. So these are some additional codes under those categories that we saw earlier. Now, I mentioned audio only codes. That was a big area of contention early on in the pandemic because so many throughout our country do not have adequate broadband access in their homes. Broadband access in rural areas has been getting better over the past several years, but out to individual domiciles is not all that good. And this is brought to light in all areas of life in the United States. kiddos that had to do remote learning and maybe didn't have access to broadband services and maybe didn't even have, tablets to do their schoolwork at home. Or individuals that didn't have the financial wherewithal to have a smartphone, to have a tablet, to have a computer at home, to be able to do a video visit and be on an interactive platform like we are today. So what CMS has said is they're not going to continue the audio only codes after the PHE, which also means that those 3 audio only codes are good through the end of 2021, since the PHE is now in 2021. What they have done is they've added a HCPCS code G2252 on an interim basis for the duration of 2021. Now, if the public health emergency goes into 2022, I would imagine that they would also extend it to the end of 2022. But this HCPCS code is for an 11-minute discussion with a medical professional during which the need for an in-person visit could be determined. So 11 to 20 minutes is the key here. And the previous Secretary of HHS said that CMS was committed to continuing to explore ways to make sure Americans had access to healthcare. All right, again, CCHP put together a fact sheet for the 2021 final physician fee schedule. Again, it really makes it a lot easier to digest all of the information about all of the codes and all the different categories of codes. We did put together a grid for our state Medicaid programs around the most commonly asked questions as we got flooded with questions last spring. So here you see what each state is doing in terms of originating sites, distance sites, communication, if it has to be, if they will allow audio only, which most states have under the pandemic. If new patients could connect to providers via telehealth for the very first time. We talked about the modifiers here. So most states are doing that GT modifier. Illinois is also asking for the POS 02 code, or the place of service code 02. Information on consent and facility fees. And that is available on our website as well. It's interesting to note when we compare the 4 states, so Indiana and some of the surrounding states, that Ohio was the first one to allow patients to be seen from home. And they did that through bills in their legislative assembly that became effective in July of 2019, prior to the pandemic hitting. In Michigan, they were on the cusp of announcing these big Medicaid changes in March, in the middle of March of last year. And so like within a day or two of each other, they did their executive order to allow patients to be at home and made that Medicaid change, which was later signed into law for permanently with the governor of Michigan in June of 2020. Here in Indiana, we've had a very successful, from a telehealth perspective, a successful legislative assembly. They're wrapping up this week. And we'll talk in a minute about Senate Bill 3 that has made permanent many of the Indiana Medicaid waivers during the public health emergency. So patients will be able to continue to be seen from home. In Illinois, they still have a lot of bills that are still on the docket. They have not made anything permanent as of yet. So in Indiana, if you're a biller or coder, I'm probably talking, preaching to the choir, but this is where you go to find information about reimbursement for telehealth for Indiana Medicaid beneficiaries. So here's your website, and you want to go under provider reference modules for the telehealth section, and there also is a medical policy manual. So here's a snapshot from the telehealth, Indiana Medicaid telehealth reimbursement. So it talks about what types of services are available. And again, this is pre-COVID, and documentation standards. And we'll come back to that in just a moment. So when you're billing for telemedicine services on or after August 23rd, 2019, they were asking for the place of service 02 and the modifier 95. Now we just saw they changed that in October of 2020 with the pandemic. Now they want GT. So Indiana Medicaid prior to COVID-19 reimbursed for live and interactive telemedicine, kind of like we're talking today, but they have not ever reimbursed for store and forward, which think of that as radiology, labs, pictures of scratches or wounds or moles or rashes on skin. For dermatology, it would be very advantageous. Back in 2017, the laws around creating that patient-provider relationship changed with the beginning of the opioid epidemic. And Indiana has codified that can happen on the first visit. And the DEA, the Drug Enforcement Agency, has also said during the pandemic that patients and providers can establish that relationship on the first visit and prescribe controlled substances on that first visit. Indiana does have a parity rule, which means that our commercial insurance in the state, United, Healthcare, Anthem, Blue Cross Blue Shield, Aetna, all of those, their policies must not be, they must not state that the patient has to be seen in person. They must provide the same amount of coverage to an individual in person as they do via telehealth. Or I should say, via telehealth as they do in person. FQHCs and RHCs, I know some of you do have RHC clinics. As far as Indiana Medicaid goes, you could already see patients as either a distant site or an originating site prior to COVID. Part of the CARES Act of last year was a huge win for RHCs and FQHCs because they could be both originating and distant site for Medicare beneficiaries. Sorry, I'm having some sinus issues with all of the snow that we're getting in spring. So here's some snippets from the Indiana Medicaid, FQHC, and RHC manuals. And you can read through that later. So here is the Senate Bill 3 that I was talking about earlier. They did a lot of cleanup in this bill. All references from telemedicine were changed to telehealth. And that's just part of this overall terminology change. When virtual services first were created, it was all telemedicine for that encounter between the patient and the provider. And then the terminology has changed to telehealth. But now we see things like mHealth for mobile health using our smartphones, eHealth for electronic health on a tablet or computer, and virtual visits and virtual settings or virtual care are really the top buzzwords today throughout the pandemic. So let's see what else. The big thing here is no location requirements for the originating site or the distant site, which means our providers that have the fragile health systems, as well as our patients who have fragile health systems, can remain safely in their homes and still seek out and provide clinical care. Oops, I didn't mean to change that yet. Okay, so this is an interesting one. I have not seen any other state do this. I'm a little bit of a policy geek, if you can't tell. So Medicaid recipient waives confidentiality, and here we're kind of talking about HIPAA, of any medical information discussed with the healthcare provider that is provided during a telehealth visit, heard by another individual in the vicinity of the patient or Medicaid recipient in this point, during a healthcare service or consultation. So, and I've sort of heard some tall tales patients trying to conduct telehealth visits in the middle of a shopping center or outside in a park or at a McDonald's because they need the Wi-Fi. This puts the onus on the patient about the privacy of their health information. And if they are not in a safe, private setting, then the provider and the provider's organization can't be held liable for any public health or private health information that gets out. There were a couple of bills around abortion and telehealth. So telehealth can't be used to provide any abortion or prescription for an abortifacient. They define healthcare services to include the following. The practitioner, and here we see a lot of movement, and this has really happened because of COVID, a lot of expansion around the types of providers that can provide services via telehealth. So an athletic trainer and a chiropractor are new. Dental hygienist is new. I think a dentist was already allowed, but even one holding a dental residency permit is allowed now. These are new. Diabetes educator is new. Genetic counselor is new. That's a huge win for those types of providers. Dietitian had already been on there. A physician had already been on there. A nurse had already been on, or I'm sorry, nurse had not been on there. Occupational therapy is new. Behavior therapist or human services professional, that's been expanded. Optometrist was on there before. Pharmacist is new. Physical therapy is new. Physician assistant had been on there before. Podiatrist and psychologist had been on there before. Respiratory care practitioners had not been on there before. Speech language pathology is new, and audiology is new. And I believe veterinarians are new too. So a lot of changes. If you need help, I neglected to put the link for that. If you need help finding this bill, please let me know, and I'll get that to you through Becky Royer. Here's the information for the DEA about prescribing controlled substances via telehealth. And here's the keywords here. They can prescribe Schedule 2 through 5 controlled substances to patients for whom they have not conducted an in-person medical evaluation. And the conditions are that it has to be a prescription provided within the scope of practice of the prescription or the person writing the prescription. It has to be an audio visual real-time session, and the practitioner has to follow state and federal law. All right, so I'm going to go really quickly through HIPAA and consent so we can talk more about patients at home. So during the public health emergency, all states throughout the United States and Medicare, so all Medicaid and Medicare programs have allowed providers to see patients via non-HIPAA compliant software like Google Hangouts or FaceTime. But we do expect HIPAA rules to be reinforced once the pandemic ends. So it's really important to make sure that you pick a technology or a video conferencing platform that is HIPAA compliant. Ones that I've seen here in Indiana that are most frequent in our region are Doxy.me, Doximity, Zoom, and Microsoft Teams. We have general consent forms. We got a lot of questions early in the pandemic about that. We have sample forms on our website. Here is the information through Indiana code, what it specifically says in the code, and the link to that. You'll get the slide, or you've already got the slides. And when you see, prior to COVID, when a provider would see a patient in the clinical setting, generally all that the patient would need on their side was a webcam and also a laptop computer. There are several different areas within telehealth. Hospitals and specialties like telestroke and tele-ICU is kind of where it started. And then we saw more integrated care between primary care and behavioral health. And in the last few years, chronic care management has been a big thing, and remote patient monitoring has become a very big thing. And primary care in schools. On the slides that have been flipping during our breaks, there was a list of 3 different telehealth webinars. Kathleen Chelmeniak from IRHA did the first one talking about school health clinics. And she does an awesome job with that. She led a program here at the IRHA for that. And then today, my presentation, the follow-up presentation provided by Nicole Watkins and Elizabeth Burrows, will be talking specifically about RHCs and FQHCs. So the modality has switched from a business to business, where a small critical access hospital or rural health clinic had the patient, and then maybe a larger urban center had the provider. So a business to business relationship, to really the patient being at home. So it's more of a business to consumer or business to patient relationship. And that has changed because all of the apps that we have available today, and even wearables, watch bands, ring bands, necklaces, whatever, that capture all of our fitness data, can be used as data points for telehealth. So in the beginning, really, to do telehealth effectively, you needed these huge carts, because that was where we were with technology. Now, traveling nurses and EMTs and paramedics often have cases in their ambulances that have all of this equipment in there, so they can take vital information from a patient en route to wherever they're going. And a disclaimer here, we're federally funded. We do not promote any single vendor. These are just examples. Again, digital stethoscopes. If you're doing heart and lung sounds, again, there's many vendors for these. These are just some examples of where we're at with technology today. Same thing with exam cameras, and a new one just came out from another vendor. This that's really lightweight, is almost the size of a stylus. Our technology TRC is TTAC, the Telehealth Technology Assessment and Resource Center. They've got a whole host of videos and toolkits if you need help picking out technology. EMR integration. So back in the 2010-2012 timeframe, when electronic health records first came out, some of the larger EMR vendors did put in patient portals. Epic put out theirs in 2022. Cerner partnered with Amwell in 2016. Allscripts partnered with Video in 2017. Meditech started virtual visits in 2017. And then Athena Health implemented a video conferencing module within their EMR in response to COVID-19 in 2020. All right, so let's talk about seeing patients from home. I've given you examples. You can go back through the slides about regulations around consent and documentation. And we've talked about that new rule in Senate Bill 3 here in Indiana. Now, it was signed by the President of the Senate on the 19th. I did not look today to see if it's actually on the governor's desk or not, but I do expect it to be signed by the governor, so probably effective July 1st of this year. When you think about all of these vital signs that typically when you go into a primary care office, they take your weight and they take your temperature and they take your blood pressure and your pulse, all of these things. For the most part, these things can be done by the patient in their home. So think about it yourself. Do you have a scale at home? Probably yes, probably about 99% of us. Do you have a thermometer at home? Probably yes, about 99% of us. Do you have a blood pressure cuff at home? Maybe 50 or 60% of us. And what about a pulse oximeter? Maybe 50% or 40% of us. So it's not that difficult to obtain those. I mentioned the changes in the Indiana law about establish that patient-provider relationship. It changed in 2017. So we have that flexibility for new patients as well as existing patients. What is important is that when you, as a provider, when you come into the virtual room to meet with your patient, you be respectful and you don't say, oh, hi. You definitely want to make sure that your name, I mean, I could change my name here to whatever, Betty Boop if I wanted to. But if I was a provider, I would probably put, MD behind my name and the facility I was with. I would probably have a backdrop of my organization in my background, or wear something with a logo of my organization so that I looked official. You want to be very professional. And the patient should too. The patient should not show up in a bikini and flip-flops for a telehealth visit just because they're at home. They still need to come and not wear a lot of clanky jewelry. They need to try and be in a quiet setting. If there's other people with either the provider or the patient, they should let the other one know. I've got a tight view on my video, and I've done that in my webcam so that you don't see the piles of stuff that I still need to organize over here, or you don't see the window over here or the door that's over there, and bring it in tight. One of the genetic counselors that I was training talked about being on with a patient, and then at the end of the visit found out that the patient's spouse was in the room too. It was okay, but the counselor was like, oh man, I'm so sorry. They would have kept the spouse engaged as part of the conversation if they'd known. Here again are these Indiana documentation standards. The documentation needs to be kept both at the originating site and the distant site. And that language, I think, will change in the future, because if the patient's at home, there technically really isn't an originating clinical site. So we'll see how that goes. But with telehealth, one of the most important things is eye contact. And it's weird, and it's taken me a long time to get used to it. But I've got two screens here. My slides are over here, and I've tried real hard just to glance at my slides and look. I arrange in using Zoom today, I arrange my thumbnails so that my thumbnail is directly underneath my webcam. So I can look at myself and not necessarily the eye of the webcam, but I should be projecting eye contact with you. Because if I'm down here making notes, or over here making notes, my voice gets muddled and you think I'm not paying attention to you. And that's not what we want to do. So here is, I did a training session for a group, and they were really concerned about physical exams with telehealth. So this is guidance from the American Telemedicine Association on live on-demand primary urgent care guidelines. So these are the things that they recommend that you obtain from a patient, especially if you're seeing them for the first time. If it's an established patient, it's probably all this should be in their medical record. So different things here about being in a clinical setting. And it's just going to be different for the provider. But by changing a few things in the provider's behavior and paying attention to a patient's facial expressions and body language, you should be able to pick up those things when a patient is just across the video screen from you. I've already talked about getting your peripherals or your vital signs. When you take best practices, say that not in Indiana, across the nation, if the patient can provide those vitals, go ahead and put them in the medical record. Just make a note that the vitals were provided by the patient. Especially with blood pressure, you might want to have a medical assistant come on the session and make sure that the patient's using that blood pressure cuff correctly before you take that reading. Again, we are vendor agnostic. Here's some examples. I showed you one earlier with a kind of a travel clinic in a box. This is a newer one from Tyto. That is very interesting. Everything is done there on the front of that screen, and it has, you just twist off and then twist on whatever you need. If you need a stethoscope or if you need an otoscope, or if you need a tongue depressor, those types of things. And this equipment is really coming down in price. So here's some examples of blood pressure cuffs, and pulse oximeters are in the same price range, around 25. This one goes up to 71, but for pulse oximeters, $25 to $40 is your general price range here. One doctor's perspective. I took my mother to the doctor, and the physician himself had all white hair, so I'm making an assumption that he was in his late 60s. And he was talking about taking his mother to an office, or doing a video visit with his mother. And his mother was complaining that her provider hadn't even touched her. And the doctor is like, but Mom, he doesn't need to. He can have you stand up and walk across the room and watches how you move and how you sit. He can tell that you've got arthritis in your hips, or whatever else it was. And I thought that was very interesting, coming from what I will call an elderly gentleman who has not been doing telehealth very long and has a lot of history with seeing patients in person. There are some videos that I can share as well, if you're interested, from Old Dominion University, that talk about seeing patients via video and doing self-guided examinations with patients to palpate their stomach, or move certain ways to see what the patient experiences as far as levels of pain. Here's some additional information. This is from the United States National Library of Medicine, the National Institute of Health. Some guidelines here about the patient weighing themselves in the morning before their telehealth visit, sitting quietly for 5 minutes before taking their blood pressure and heart rate, taking their temperature and their pulse ox. So just some guidance there. And then if a patient does need any follow-up radiology, MRI, labs, then they should be able to be referred to a local clinic to get those taken. Here's some additional references. Here's the link to the YouTube group of videos from Old Dominion that I mentioned. Some other things about physical examinations. This is some information from one of my sister TRCs in California, but these things are so important. And this is what we've been promoting all along with telehealth, that it increases access to healthcare. It can improve health outcomes. It can reduce healthcare spend by seeing a patient sooner. I like to use the example of a kiddo that has access to school telehealth. So they go see the nurse at school, or whoever is acting in that role at school, and they determine that there's a need to see a primary care, a pediatrician or a primary care physician. And they conduct that visit. They've got a digital otoscope to see in the kiddo's ear, and they've diagnosed a earache while the kid's still at school. The parent or guardian didn't have to take off work to take the kiddo in to see the doctor. If the kid doesn't have a relationship with a primary care doctor, then the kiddo is seen early in the ear infection, and they're not waiting until his eardrum bursts before he goes to the ER. So we're saving money there. The primary care visit's only $150. An ER visit's at least $1,000. We're addressing shortages and misdistribution of healthcare providers, because many healthcare providers, regardless of their profession, of their discipline, are located in urban areas, not in rural areas. Telehealth supports clinical education programs, just like we're doing today. It improves organizational productivity, because the employee, when they have a telehealth visit, they don't have to, take 2 or 3 hours off of work to drive to the location of their physician or provider, have the visit, and come back. So we're more productive at work. Here's some statistics. Studies show that home monitoring of chronic diseases can reduce hospital visits as much as 50%. Readmissions within 30 days following a heart failure episode have been at 20% on average, and a monitoring program can bring that down to 4% readmissions. In the episodes of stroke, the reversing the consequences of that stroke have gone from 15% up to 85% of reversing the effects of a stroke with the use of telestroke programs. And this last one here for EICUs or electronic intensive care units, they have been shown to reduce mortality rates by 15 to 30%, reducing the length of stay as well. So just some lessons learned from this past year. Many providers and many patients have really embraced telehealth. My two favorite quotes, one from Seema Verma, the former CMS administrator in the Trump administration, said in an interview last summer that the genie is out of the bottle. It's very difficult to put the genie back in the bottle. And then earlier this year, I was attending a virtual event by the National Rural Health Association, and their VP of Government Affairs, Carrie Cochran-McLean, said that the toothpaste is out of the tube. Now, I don't know about you, but I have had toddlers in my life, and maybe you have children or grandchildren or have been around children. The first time that kiddo grabs the toothpaste and it spurts all over the bathroom, there is no way it's going back in the tube. So my opinion is that telehealth is very bright and is really going to transform the way we deliver healthcare in the United States and around the world. One last quote, and this is from a book called Who Moved My Cheese by Spencer Johnson. The handwriting on the wall. Change happens. They keep moving the cheese. Anticipate change. Get ready for the cheese to move. Monitor change. Smell the cheese often so you know when it's getting old. Adapt to change quickly. The quicker you let go of the old cheese, the sooner you can enjoy the new cheese. Change. Move with the cheese. Enjoy change. Savor the adventure and enjoy the taste of the new cheese. Be ready to change quickly and enjoy it again because they keep moving the cheese. So there's my contact information, and I'm happy to answer any questions.
Thanks, Becky. That was a comprehensive presentation, but you covered a lot of good information and addressed a lot of the questions that, we've had come in. And I know that Joyce and David have heard over time as they have met with hospitals too. A couple of common questions that we have that you might address is on that very first telehealth presentation, there was mention of a simulation center in Indianapolis that people could practice. If you could talk to that a bit.
Sure. It's not up and running just yet. We did receive some funding from the CARES Act last spring, and we have purchased a lot of equipment, some of which you saw in pictures on my slides. Our goal when we can meet back in person again is to hold training sessions at the Indianapolis office where we normally gather in the Cranert room. We have a suite on the 3rd floor where we have all that equipment. So once it's safe again, our hope is with our in-person conference in July in South Bend to start showing that equipment off, and then do additional training sessions and be able to make appointments for folks to come in and try out 3 or 4 different types of stethoscopes or otoscopes or the like. So folks interested in that can certainly contact me.
Great. Another question in chat is, are we seeing any negative trends related to telehealth as far as liability issues?
Yeah, there have been, and I don't have a list off the top of my head. Please email me if you want more information. There have been some court claims around telehealth and liability, but not very many.
Good, good. You had mentioned in the beginning too about the telehealth fact sheet for 2021 from MLN. Is there any place specific individuals need to be signed up differently than MLN notifications? Is there one
No,
specific
well,
for telehealth?
I will, let me stop sharing and I'll put in the link. If you want to sign up for our UMTRC newsletter that goes out at the beginning of each month, we certainly, as soon as we know that it's hit, we'll be posting it on our website and sending it out via mass email.
Perfect. Another question that came in are, you talked about the confidentiality for patients and them being in a confidential location and it potentially becoming their responsibility to make sure that they are in a quiet, secluded environment. Are there processes that we should be thinking about to document that we have alerted the patient to this?
Yeah, that's a good idea. We've got a lot of fact or infographics on our website that were created by one of our interns. I don't know that he addresses that, but that would be a good thing. We do, and when we talk with specific organizations, is about how do they do their HIPAA paperwork on a regular basis, and maybe you want to integrate a telehealth consent form into your annual HIPAA paperwork. Other organizations say that their legislative leads in their organization have said, well, by the patient accepting a telehealth visit, then basically they're implying their consent so that they don't ask for a separate consent. So, but yeah, there's lots of different ways to do that.
Okay, great, great. Well, yeah, if you share that link so that individuals can get signed up for your newsletter and receive those notifications, that would be awesome. Thank you so much, Becky. We always appreciate your presentations and they're always, always very informative.